Hello. Hello, everyone.
Hello, ma'am.
Huh.
Can you hear me?
Yes. It's audible.
Yeah.
Shall we start?
It's 7:30, but still the attendees are not much, so we can wait another 5 minutes and then start.
Okay, no problem. Okay. তাতে ক্যামেরা লাগানো নেই না?
Recording in progress. Recording in progress.
Yes, sir. Yes, sir. I'm there. Hello, Arif sir, are you there? No, we are not able to hear you here. I mean,
ঠিক আছে, ঠিক আছে।
hello, sir. Arif sir. Hello. Arif sir, are you there? We can see the screen but cannot hear you. So, ma'am, I think we should start. It's already 7:35.
Okay.
So, Dr. Arnoy, will you start the program? We have already started recording.
Okay. Okay, welcome all. Hello to this. Hello.
Yes, yes.
Is it audible?
Yeah,
Yes.
yeah, it's audible.
Yes. Welcome all. This is another evening of scientific session. This is for AROI WB Basics of Contouring and Radiotherapy Planning session, Module 4. It is on genitourinary malignancy. As usual, the session will start with radiological anatomy for radiation oncologist on genitourinary malignancy. That will be spoken by Dr. Arif Faizan, consultant radiologist, Narayana Super Speciality Hospital, and coordinated by Dr. Monideepa Mondol, consultant radiation oncologist of Narayana Super Speciality Hospital. So we can start now.
Yes, so Dr. Arif, sir, are you there? Some audio problem is going on. Check it, sir.
Arif sir is not muted, but
Yes, yes, he is unmuted only, but we cannot hear him. I think I should give a call.
Monideepa? Hello?
Yes, sir. Yes, ma'am. I have called him. I think there is some problem because
Okay, okay. No problem. No
we are
problem.
not able to hear him. So he is again logging in. After logging out, he is again trying to log in.
Okay, okay. I think many of the students have joined already.
Yeah, ma'am. Almost
Okay.
30, total 90, 29. Yes, sir. Hello?
Yeah, I'm audible.
Yeah, yes, sir. Audible. Now audible.
Yeah, thank you.
So please start your presentation.
Yeah, just a minute.
Yes.
Hello all, a good evening to all of you. Actually, I was supposed to speak on radiological contouring for the urogenital tumor. It will be like that only, but the heading here is something different. So we will be discussing the anatomy only with respect to the radiation planning and all. But we will be emphasizing mainly on the prostatic anatomy today. So first of all, the prostate has been divided into different zones. Okay, so we have transition zone, central zone, and there is very small component that is called anterior fibromuscular stroma, and fourth is peripheral zone. So transition zone is basically occupies most of the prostate, and it becomes larger and larger as the patient ages because of the benign prostatic hyperplasia. Transition zone is basically the zone which surrounds the prostatic urethra. So urethra is in midline, so transition zone we will be seeing mostly in the midline of the prostate. Central zone is the zone which lies at the base of the prostate, and it is posterior to the transition zone. And central zone is the zone which surrounds the left and right ejaculatory duct. The third is anterior fibromuscular stroma, is very small area of tissue that is situated on the anterior side of the prostate. anterior fibromuscular stroma is important in this respect, that this region comprises of fibrotic component, so it will appear T2 hypointense on MR images that may sometime confuse with the tumor, though it is a normal structure, but it might get confused with the tumor. Peripheral zone is the last zone which I will talk about, is basically present at the posterior and the lateral side of the prostate. As we all know, most of the cancer arises in the prostate zone. However, this zone is palpated on digital rectal examination, and by palpating it, we can be a bit suspicious that not that much palpable. So we need to take the help of MRI for detection of any tumor over there. But having said that, very less amount of tumor occurs in the transition zone or in the central zone. We will see to that in our discussion. Here we have sagittal schematic diagram of the prostate. As we can see, here is the bladder. This is white structure is the prostate. This is the base of the prostate, and this is the apex. In the center lies the prostate. We have the seminal vesicle, and this is the ejaculatory duct that is opening at the verumontanum. So as we described just right now, that the transition zone is basically surrounds the prostatic urethra. So here is the transition zone which lies in the center, and this is around the prostatic urethra. As we can infer from this diagram, most of the transition zone are present at the base of the prostate and at the mid substance. As we go further down at the apex, there's not much of the transition zone. In the next slide, we can see the central zone that we just described is the zone that is present at the posterior aspect of the prostate. Similarly, here we can see that this central zone is predominantly found at the base and the mid substance, and even less at the apex. This central zone surrounds the ejaculatory duct. As we can see here, the seminal vesicle is opening here. So this central zone basically surrounds the ejaculatory duct present at the posterior aspect and not found at the apex. This is the anterior fibromuscular stroma. Anterior fib, as the name implies, this is present anteriorly in the prostate gland. As similar to transition zone or the central zone, the amount of anterior fibromuscular stroma becomes less as we go down. And in this slide, we see the peripheral zone that is mostly present at the posterior and the lateral aspect of the gland surrounding central and the transition zone. Even though a bit of anterior fibromuscular stroma you can see is as we go deeper in the apex. So we are done with the schematic diagram here, and a bit of MRI anatomy we will discuss. I apologize, we don't have that images. As you see, the bladder is, this is the bladder, and behind the bladder we have the seminal vesicle. One thing I forgot to mention, that when we talk about the prostatic cancer or prostatic anatomy, the images that we use is basically T2 weighted images. T1 weighted images or any other images are not that much useful in prostate. So when we will talk about the prostatic anatomy, it implies that we are talking about the T2 weighted images. So it is a T2 weighted images. You can see the urine in the bladder is white, and similarly secretions in the seminal vesicle is also white. So T2 weighted images will have fluid as bright. So this is the seminal vesicle with secretions inside here, and this is the rectum. Here we see few blood vessels, dot-like blood vessels here. Here we see a linear kind of hypointerous structure that is medial to the acetabulum, and this is the obturator internus. In the further slide, we see the base of the prostate here, and then the rectum, and here is the levator animuscle on both the sides. Obturator internus muscle on both sides are now clearly visualized here. And these are the pelvic side wall formed by the acetabulum. This is again bladder. This is mid substance of the prostate. And this is rectum, again levator animuscle. Going further down, at the mid substance, we can see two dot-like structure, posterior and outside to the prostate. These are very important structure, and as you can see the labeled diagram, that these are neurovascular bundle. So neurovascular bundle on the right side is present at 7 to 8 o'clock, and on the left side it is present around 5 o'clock. I will come to the capsule later on. So going back to this slide, we can see there's a large heterogeneous area here limited by a hypointense line, T2 hypointense line. And again, there's another area which is also limited by the hypointense line, but this area is white and this is grayish. So we have our transitional zone here, and transition zone is limited by also limited by a capsule or pseudo capsule. So where is the true capsule? Here is the true capsule of the prostate, which lies the peripheral zone. Here the peripheral zone has been compressed nodule in a patient of benign prostatic hyperplasia. So how to recognize the true and the false capsule? So the true capsule will lie at the outermost aspect of the prostate gland, close to the rectum. When we see when we see two lines in the prostate, the inner line will be the capsule that will be limiting the transition zone, and outer line will be due to the true capsule of the prostate limiting the peripheral zone. Am I audible?
Yes, sir, you are audible.
Thank you. So capsule that is limiting the peripheral zone. I will tell you here that a normal peripheral zone of the prostate should appear white on T2 weighted images. It is to be abnormal. So here is the peripheral zone as we discussed earlier, and it is getting compressed by the transition zone. Here again, we can see the rectum and the levator animuscle, and then here is the obturator internal muscle. Going further down, we have this white structure. As urethra also contains urine, so it will appear bright on T2 weighted images. Further down, it is the continuation of the urethra and the rectum and the levator animuscle and the obturator internus muscle. Can we discuss a bit of sectoral anatomy?
Yes, sir, you can.
Yeah. So sectoral anatomy is basically a more refined division of the prostate, which we radiologists use while describing a lesion. So instead of writing a lesion in the right lobe of the prostate or the left lobe of the prostate, it has been a bit more refined. So it would be a good idea if we can have a bit of discussion about sectoral anatomy. So we have divided the prostate, base, mid substance, and the apex into 6 sectors on each side. For example, this section, the section of the base that has been taken here has right lobe and the left lobe. The right lobe has 6 sectors. As we have discussed earlier, that the anterior fibromuscular stroma is present anteriorly. So this is the anterior fibromuscular stroma, and then transition zone has been divided into the anterior and the posterior, and peripheral zone has been divided into the anterior and posterior component, and we have the central zone here. Similarly, we have divided the mid substance of the prostate into 6 sectors that has been labeled over here, and the apex is also divided into the 6 sectors on each side. Here the point to ponder is at the base, we have central zone at the most posterior aspect of the gland. So if we have axial anatomy of the MRI, and we have the section at the base, then we should not be, confuse this region with the peripheral zone, because at the base, you will have central zone at the posteriormost aspect of the gland. This central zone will get replaced by the peripheral zone, medial peripheral zone, in the section at the mid substance and the apex. So at the base, we will be having central zone at the posterior aspect of the prostate, and at the mid substance and the apex, it will be peripheral zone only. The CT anatomy, I think it is not that elaborate. We will be elaborating this CT anatomy later on, but a very brief review. This is the urinary bladder. Here we can see this is a urine-filled thin-walled structure, that is urinary bladder. The bow tie configuration of the seminal vesicle is visible here. And this is the rectum, the pararectal fat, and then a bit of obturator internus muscle. These are the vessel. This is the external iliac artery, and this is the vein. This is the prostate, and behind the bladder and the rectum posterior to the prostate, obturator internus muscle again here. This is lower down section, so a very small section of bladder is here. Much of this is occupied by the prostate and the rectum, and these are the levator animuscle. So I apologize, I could not have many more images for the CT. So coming to my favorite, that is for a radiologist, prostatic cancer. And I'm not going very deeply into the prostatic cancer, but only share few very important points. So as we have discussed earlier, the most of the prostatic cancer arises in the peripheral zone. So the first question arises, how you can say that a lesion in the peripheral zone is a cancerous, or is it a benign lesion? So it has to fulfill basically 2 broad criteria. If we see any lesion in the peripheral zone, and if the lesion is hypointense on T2 weighted images, And if it is ill-defined, then we should raise the suspicion that in the peripheral zone, this lesion appears a bit suspicious. Less suspicious lesions are those lesions which are bilateral and symmetrical, or if there is diffuse distribution of the T2 hypointensity across whole of the length of the prostate. So if the lesion is very large and it is involving almost whole of the peripheral zone, even it is T2 hypointense, then it might not be a cancer, or it might be fibrosis or inflammation or something like that. Sharply demarcated focus of hypointensity or similarly wedge-shaped lesion, these are also not that much suspicious for the cancer. If a lesion is ill-defined and hypointense, then it is suspicious for a cancer in the peripheral zone. Here also I would like to mention the dominant sequence we look in the peripheral zone for detection of cancer is diffusion weighted images. Along T2 weighted images is very significant, but diffusion weighted image is the dominant sequence. If something, let me say, if a lesion is ill-defined and hypointense on T2 weighted images, but it is not showing any restricted diffusion. I mean, if it is not bright on diffusion weighted images, then this lesion becomes less suspicious, even though it is hypointense as well as ill-defined on T2 weighted images. So peripheral zone dominant sequence on MRI for detection of tumor is diffusion. But for transition zone, it is T2 weighted images. So we can remember like this, that for transition zone, T for T2 weighted images is the dominant sequence, and for peripheral zone, it is diffusion weighted. Very brief introduction with the pyrites in the peripheral zone. So we have divided the lesion into the 5 categories depending upon the suspicion of the cancer within it. Pyrites 1 lesion are the normal. We can see here, we have the T2 weighted images. This is, as we had discussed earlier, this is the central zone, and this is the capsule of the central zone. Peripheral zone on the T2 weighted images will be bright. It should not, a normal peripheral zone should not be grayish or any other signal intensity. It should be bright on the T2 weighted images. And this is the outer capsule of the true capsule of the prostate. So we don't see any lesion here. Similarly, we don't have anything abnormal on diffusion or ADC. So this is normal. This is pyrites 1. Compare it with the next lesion. Here we have, this area is normal. This area is normal, but we have something here in the wedge-shaped kind of, which shows a bit of hyperintensity of diffusion and a bit of hypointensity on ADC. So though this lesion is T2 hypointense, and we can say it is a bit ill-defined, but there's nothing on the diffusion on the ADC, so it is not a cancer. So it is also a benign lesion, and we will categorize as this lesion as pyrites 2 only. This is the, now this lesion, you can see we have normal peripheral T2 hyperintensity here, a bit of heterogeneity, but not significant. But when we come to this lobe, right lobe, we see a strand-like, thick band-like structure here, which is T2 hypointense. It is not that sharply demarcated, and it is showing some amount of diffusion restriction here. And again, some amount of glow signal on ADC. When we have T2 hypointense lesion with some amount of restricted diffusion and low signal intensity, it becomes suspicious. So it is a suspicious lesion. It is a pyrites 3 lesion. And then further, we can see this peripheral zone, a lesion is here. And something is here as well on the right side as well. But in between, there is no lesion. Similarly, we can see there is some hyperintensity on diffusion on in both the lesion, and gross amount of blackening or hypointensity on ADC. So this is very, very suspicious lesion. We will keep it as Pyrites 4 lesion. Since these lesions are less than 1.5 centimeter, these are in Pyrites 4 category. If this lesion would have been more than 1.5 centimeter, we would have characterized this as Pyrites 5, as we have this lesion that is hypointense on T2 weighted images and diffusion restriction, I mean the whiteness on the diffusion weighted images and low signal intensity on the ADC images. Since this lesion is similar to this lesion, but size is more than 1.5 centimeter, so it will be Pyrites 5 lesion. Pyrites 5 is basically significant cancer. Here I would like to point one more thing. As you can see, this lesion is basically abutting over the capsule. This is the capsule and it is abutting over the capsule. And there is some stranding in the region of the capsule. So we can say here that there may be some capsular breach over here. So this was all about the pyrites in the peripheral zone. Now, how we are going to say something in the transition zone as being suspicious for a cancer. So a cancerous lesion in the transition zone will be non-circumscribed. It means we cannot draw a line along a lesion in a transition zone, then this lesion can be a tumor. The lesion should be homogeneous. Few of us must have noticed in the previous slide that we discussed that there was gross amount of heterogeneity in the central zone, but those lesions were BPH nodule. So a BPH nodule will be heterogeneous, but a cancer will be homogeneous. So a lesion that is non-circumscribed, homogeneous, relatively T2 hypointense, smudged appearance of T2 weighted images, or it is droplet-like shape, or it is lens-like, or it is having speculative margin. These are all criteria for a suspicious lesion in transition zone. A homogeneous non-circumscribed lesion with T2 hypointensity, erased charcoal appearance, lens-like or droplet-like, or with speculative margin. I will show you some example here. So as we discussed, this is the peripheral zone and this is the transition zone. This lesion in the transition zone is very, very heterogeneous. So with no abnormal signal intensity on the ADC or on the diffusion weighted images. So this heterogeneous lesion is prostatic nodule in benign hyperplasia. The lesion, the suspicious lesion should be uniformly hypointense like this. But this is also not very suspicious. Why? Because we can draw a line all around the lesion. And similarly, there is not much low signal intensity on ADC or restricted diffusion on DWI images. So this is also a Pyrites 2 lesion, likely to be benign. Now the game starts here. A lesion that is ill-defined. This whole lesion is not ill-defined, but if you go to the periphery, you cannot draw a line along its periphery at this end. And similarly, there is low signal intensity on ADC images with subtle increase restricted diffusion, I mean a bit of brightness on the diffusion. So this becomes suspicious for a neoplastic lesion. This is a Pyrites 3 lesion. Contrast this with the Pyrites 4 lesion. This is a lenticular shaped lesion along the capsule of the central zone, showing significant low signal intensity on ADC images and significant brightness on the diffusion. So it is a very, very suspicious lesion for a tumor. So it is Pyrites 4. Similarly, this lesion is more than 1.5 centimeter in size with similar characteristics such as low signal intensity on ADC and increased brightness on diffusion weighted, but since the size is more than 1.5 centimeter, so we will characterize it as Pyrites 5 lesion. very suspicious for a significant cancer. So having done with the pyrites, here another example of a pyrites 4 lesion, we can see the capsule here, prostatic capsule. This is the peripheral zone appearing bright, normal peripheral zone appearing bright, normal peripheral zone appearing bright. This is the tumor zone. This whole is not a tumor zone. We have two kind of signal intensity here. One is very low and these are a bit low. So this is tumor. This might be the inflammation induced by the tumor. And again, we can see here the capsule that is irregular. So there may be some capsular breach. In continuation of this lesion, we can see there's restricted diffusion on DWI and there is low signal intensity on the ADC. So it is a pyrites 4 lesion. It is a locally advanced prostatic cancer. Here the prostatic anatomy has been completely distorted and the tumor tissue can be seen to be outside the capsule. The capsule is not visualized. Here we can see a bit of seminal vesicle, but here the seminal vesicle has been infiltrated. So it is similarly the fat print with the bladder is also not maintained. So it is a locally advanced prostatic cancer. Here is another lesion in the transition zone. This lesion, we cannot draw a line around the lesion. This is T2 hypointense. This is showing low signal intensity on ADC and brightness on the diffusion. So it is a tumor in the transition zone. So it was all about the prostate. The one thing I just wanted to share that the rectosigmoid junction for us as a radiologist is the region where the rectum gets separated from the sacrum. It starts separating from the sacrum. So if we draw a line along the posterior margin of the rectum, we can see that at this point it is getting separated. In fact, at this point is getting separated. So probably the rectosigmoid junction will be here only. These are the things which I wanted to share with you. I know that I haven't done what I supposed to, but this was my first presentation. I hope to meet you next time with better material and better way of presentation. Thank you so much. Hello.
Yes, sir. Thank you. And
Thank you.
can we see the normal CT images of a prostate cancer patient? CT images. Can you scroll down and see the CT images, sir?
Okay, I will. Can I share your screen? I mean, you were having that anatomy.
My screen. Okay. Yeah, is it visible now?
Yes.
So actually, for contouring purpose, for prostate, we have recently developed. Hello.
Hello.
Am I audible?
Yes.
Yes, for contouring purpose in our radiation oncology, for prostate, we have H2 ACROB guideline, which has been given in 2018. And it is mainly based on CT and MRI. They have given guidelines for CT as well as MRI. But here we will see also that MRI helps us a lot to define our prostate and seminal vesicle. So whenever possible, and you should always, to the resident, you should always fuse the T2 weighted images of the MRI along with your planning CT to delineate prostate and seminal vesicle. Also, for contouring purpose, you should give IV contrast and to the planning city when you are doing planning city. And also important point is that you should give bladder protocol, that means fixed filling protocol for the bladder, as well as do something about the rectal filling. We usually use laxatives before doing the planning city. And in that same position, we'll fuse the planning MRI, only the T2 weighted images will fuse, and then we will just contour it. And we'll follow the AROI guidelines, and we will see that this is the CT images as I have loaded here. And if we can see here that this is the prostate, and we cannot, important thing is to identify the apex of the prostate, which is very difficult to do in a CT scan. Arif, so can you say that is it possible to identify or delineate the apex of prostate in this CT scan?
No, we also, I mean, we also get difficulty in separating the apex of the prostate from the bulb of the penis or an adjacent structure. So, I mean, on CT scan, it is very hard to separate the apex of the prostate from the rest of the structure. MRI is basically ideal.
So actually the guideline says that in CT scan, the prostatic apex is 1 centimeter above the upper limit of the penile bulb. So where from the penile bulb start, 1 centimeter above that is the apex, and we should contour till that. And then defining the lateral border of the prostate is also becoming very difficult in the CT, because we cannot differentiate it from the levator ani muscle and also the urogenital diaphragm. Another thing is that defining the anterior border of the prostate. Anterior border of the prostate, here we cannot have a definite plane. If we can zoom it here, there is no definite plane in, we can see, but there is a definite retropubic space which is present. And in absence of visualization of that retropubic space, which contains some fatty tissue and a venous plexus, we have to take the whole volume. So actually we are contouring more in a planning CT if we are doing it only a CT based, because the anterior fibromuscular fatty stroma is not appreciated here better. Also, when we are scrolling high, we are not able to see the where the actually the base is. If it is, there is benign prostatic hypertrophy, then it projects into the base of the bladder, and we have to take the entire entire thing into the CTV. So, and another thing is the identifying the seminal vesicle. So seminal vesicle is these two structure. Am I right, Dr. Arif?
Yes.
Yes. So these are the two structures, and in intermediate and high risk, we usually take the seminal vesicle, particularly if seminal vesicle is involved, then whole of the seminal vesicle. And if it is in the intermediate, high intermediate risk and high risk, then a portion of the seminal vesicle has to be included. Also, important thing is that defining the posterior border of our contour, because this is the rectum and it is the dose limiting structure, and here we should be very much cautious about it, so that we don't include the structure, our contours, to the rectum. And these all things are very much visible when we do it in the MRI. Already sir has shown the MRI pictures, and I will just show another MRI of our patient. And this is a T2 weighted MR images. And so if we zoom it, so those things which cannot be seen can be seen here, like prostatic apex. The important thing, as I said, is the prostatic apex, and here it is the urethra. And prostatic apex, we can definitely recognize it here much better. Also, we can recognize it from the surrounding levator ani muscles. And the anteriorly, we can differentiate it from the retropubic fat. And we can clearly delineate the seminal vesicle, as already said by sir, that it will take hyper intensity because there are secretions in the prostate, in the seminal vesicle. So we can definitely differentiate in between this. So those important structures which we cannot differentiate in the CT can be easily differentiated in the MRI. So therefore, it is very much important to fuse your MRI, T2-weighted MRI with your CT during your delineations. So that is important output from my side, from radiation oncologist side. And if you have any question, please type in the chat box, or we can go to our next section. Yes, so there is a question that to Arif sir is that can you show us the urogenital diaphragm in CT?
Yeah, good question. But it is, I mean, we can see the urogenital diaphragm on CT, but it is very difficult, I suppose. Urogenital diaphragm on MRI is more visualized, more clearly visualized. But on CT, I think it is very difficult to see urogenital diaphragm. I mean, if we scroll down,
Yes, sir.
very, yeah, up,
Okay.
down, please, a bit. Oh, yeah, and further, and further, and further. A bit of urogenital diaphragm, we can see a bit up. Yeah. In this region, a bit of urogenital diaphragm. I mean, we can assume that the urogenital diaphragm may be here, somewhere here, but it is not that clearly visualized on the CT scan.
Okay. And
Sir,
it is
there is another question.
Yeah.
Request, can you, sir, please show the phenyl bulb?
Okay, so it is in the CT phenyl bulb. Can you?
Yes, if you, I mean, continue posteriorly from the membranous part of the phenyl region and come posteriorly up this down, please. Yeah, this region may be the phenyl bulb. Yeah, this is a continue posteriorly, and then you will come to the, and you can see some amount of fat between this structure and the rest of the structure. Here's the fat. So this is the phenyl bulb.
And I think there are no other questions as such. Okay. So thank you, sir. Thank you for your presentation.
Thank you. Thank you.
Madam, are you here?
Madam, can you hear us?
Yeah, or not, please announce them the next. I think Madam will be joining. Madam is here joining, already joined.
So,
can you announce?
So our next topic is planning of RT planning of common pelvic tumors, and the speaker will be Dr. Amitabh Roy. Sir, over to you, please.
Am I audible?
Yes, sir, you are.
Okay, so after a lot of radiology and a lot of discussions about how we actually try and delineate our tumors, we will be taking a detour into history probably, because most of what I will be talking about today is hardly practiced in most radiation oncology centers to the best of my knowledge, but it is important for us to have a holistic view of how we got here. So with that in mind, I would actually like to congratulate the organizing committee for choosing a topic which basically made me go back and look at what we used to do 15-20 years back while we were residents, and how we changed from there to where we are today. So I will confine myself to talking only about the 2D planning of most urological malignancies, and my slides are visible?
Yes, sir. Yes, sir.
Yeah, okay. So over the next few minutes, I will be basically discussing about urological malignancies and 2D planning for the same. So to set the the scope of today's presentation, we are essentially looking at these subsites. And these would be non-specific for gender, which would include kidney, ureter, urinary bladder, urethra, and gender-specific subsites like prostate, penis, vulva, and testes. Now, I thought very hard about how much we should be covering to probably be able to, fit in the entire program into the time frame that has been provided, and also not exceed the information overload statistics that we are all aware of. So this is where we have confined ourselves for today. We are going to specifically talk about kidney, urinary bladder, prostate, and testes. Now, I was very, sort of interested in including penile cancers in today's discussion, but then what I realized was that would probably require a different presentation altogether, given the fact that penile cancers, the treatment protocols have changed drastically over the last few years. And if we do talk about radiotherapy for curative intent in penile cancers, we cannot avoid brachytherapy there. So it would be unjust of me to just talk about how to treat penile cancers with external beam, and that probably would require a separate discussion altogether. And I've already spoken to Dr. Costa regarding this, and I may also direct my resident friends here today to a fantastic presentation by Dr. Kanucharan Patro, one of our very good friends and one of the best teachers around, which he will be very happy to share with any one of you. He has a long and a very, very comprehensive presentation on how to plan penis cancers with conventional radiotherapy techniques. So I would be leaving that out for today's discussion, moving directly into the first subsite and kidney. So I know everybody must have been really taken aback as to how was kidney a part of this. And we all know about the futility of adjuvant radiotherapy in renal cell carcinoma. But again, Wilms tumor has been one of the main areas for the success of radiotherapy in pediatric cancers, and we cannot avoid radiation in a majority of Wilms tumor patients. So this would essentially be a recapitulation of Wilms tumor for most of the senior colleagues present here. And for all the juniors, Wilms tumors is a very, very scoring area, because unlike most subsites for radiotherapy and treatment protocols in oncology, Wilms tumor has a fantastic progression of data collection and evidence, leading up to a point in time where we are more or less certain that the National Wilms Tumor Study Group protocols from 1 to 5 have actually helped us establish the treatment of Wilms tumor in a much better way as compared to many, many other cancers. So I would definitely encourage you to go and look at that for a more comprehensive understanding of how Wilms tumors can be, treated in the context of radiotherapy and also from the context of chemotherapy and surgery. We will confine our discussion to a small part of this, and that is the indications for radiotherapy in Wilms tumor. And those are more or less standard exam questions. So stage 2, unfavorable histology, stage 3 and 4, favorable as well as unfavorable histology for a local recurrence, as well as palliative radiotherapy for metastatic disease. And I will try to, bring out the differences for palliative radiotherapy in Wilms tumor versus palliative radiation in other cancers that we usually treat. That is primarily because Wilms is a very, very radiosensitive cancer, and you could actually be looking at very long-term survivals, even with metastatic disease in Wilms tumor. So what are the principles of radiotherapy in Wilms tumor? And this is something that I believe even the postgraduate entrance exam question banks have now included, is that radiotherapy should be started within 10 days of surgery in Wilms tumor. There is no change in radiotherapy doses from the histology point of view, except that rhabdoid tumors are treated as a separate entity and they don't really follow the natural history of Wilms tumor the way we usually see it. So coming to target regions, so when we talk about conventional radiation, although we are talking mainly about radiation portals and doses and so on and so forth, but then at the back of your mind, you should have an idea about what exactly is being treated when you're treating a particular area. So the target volume should encompass the tumor bed plus the site of excised kidney with a 2 to 3 centimeter margin. The entire vertebral body needs to be encompassed, and this is extremely important because Wilms tumor is a tumor of the pediatric age group, which is basically growing bones. And if you make the mistake of treating only one half of the vertebra, then you will end up with scoliosis in your patient when they grow up. So this is extremely important for from the radiotherapy planning perspective. For very early tumors in stage 2 tumors where radiation is indicated, you could treat the tumor bed only, but everything beyond that, you have to decide on the area of radiation depending on the extent of disease. So anything with positive hilar nodes, positive para-aortic nodes, gross or microscopic residuum confined to the flank, you treat the entire flank, which is basically the operative bed, crossing the midline to include bilateral para-aortic nodes. If you see anything beyond that, which is peritoneal seeding or gross residual abdominal disease, or, and this I cannot emphasize enough, you have to talk to your surgeon regarding whether there was any spillage during surgery. And this is something which is going to make you change your treatment portals. Also, preoperative intraperitoneal rupture, something that the NWTS protocols are sometimes criticized for. Why? Is because Wilms tumor is one of those areas in oncology where you have two different and very interesting schools of treatment. One is the SIOP protocol, where you could actually start the treatment even without doing a biopsy. And the other is the NWTS protocol, which forbids treatment without having a histopathology of the disease. So one of the criticisms there is in trying to get a biopsy for advanced disease, you may actually be leading to increasing the total of radiotherapy or increasing the volume of radiotherapy. And what is that increase? It is essentially the whole abdomen with a boost the tumor of more than 3 centimeters, and you need to shield the acetabulum and the femoral heads again because you're treating a growing child. For lung metastasis, you treat the whole lung bilaterally and not just like what you do for SABR, where you treat the tumor only without too many margins around it. So this is a summary of doses. So you would treat the whole abdomen to a dose of 10 gray at 150 centigrade per fraction. So this, as you will probably make out, is less than what we would call conventionally fractionated radiotherapy. So this is something where you're reducing the dose per fraction, primarily because you're able to achieve the tumor control and the outcomes even with lower doses, given the high radiosensitivity of the disease you're treating. If you have a residual, then you are going to add on a 10 gray boost at the same dose fractionation schedule, and have to limit the dose to the remaining kidney, if any, to less than 14.4 gray. We'll come to how you do that subsequently in the next slide. If you're dealing with lung metastasis, then you're going to do 12 gray whole lung radiation in 8 fractions. We'll see the portals for that. For liver metastasis, you need 19.8 gray whole liver radiation in 11 fractions, and you do not do this with conventional radiation. You have to do a volumetric dose prescription when you're doing whole liver radiotherapy. If it is brain mets, then you do 36.6 gray whole brain in 17 fractions, or 21.6 gray whole brain plus 10.8 gray IMRT or SRST boost, which again is outside the scope for today's discussion. So we confine ourselves to a whole brain RT of 36.6 in 17 fractions. If you have unresected lymph nodes, then it's 19.8 in 11. If it is bone metastasis, it's 25.2 gray in 14 fractions. Why I brought this out is because this gives you a different perspective of treatment for metastatic disease. So we are typically told about hypofractionated short course treatments, or with modern radiotherapy facilities, single fraction or SABR or SRS based treatments. But this is one area where you basically kind of look at metastatic disease very differently as compared to you would in other cases. So what is flank radiation that we were talking about? This, as you can see in the diagram here, is basically including the entire post-op bed going across the midline to cover the entire vertebral body and shield the tangential abdominal wall to decrease the skin reactions at this area. And so that would encompass, as I mentioned, and 2 to 3 centimeters margin should be given circumferentially to the post-op bed. If you're doing 3D plans, then this is how we would do it. The beam energies are as specified because you're treating children. Despite having abdominal disease, you would not want to use high energy radiation beams. What about whole abdominal radiation? It is indicated in very few patients, as mentioned. Again, the beam energy is between 4 to 6. And what are you shielding here? You're basically shielding the opposite kidney, especially in the posterior portals with 5 half layer shields. And you're shielding the acetabular and the femoral heads. So this is how things would work out for whole abdominal radiation. The superior border would be the dome of the diaphragm, which would be at the nipple. For a child, the inferior border would be the inferior border of the obturative foramen or the pubic symphysis, as you can see there. The lateral border should be at the lateral peritoneal reflection, that is essentially going across and covering the entire abdomen. And remember the renal shields and the proximal femoral shields, as you can see in this diagram. What about lung radiation? The anterior portal for bilateral pulmonary radiation, the superior border is 3 centimeters above the middle of the third of the clavicle. The inferior border is below the postophrenic angles, which is below the xiphisternum of the level of the L1 or the transpyloric plane. The lateral borders are at the lateral border of the areola or the nipple, and you basically shielding the femoral head as well as the larynx if it comes into your field. So this, as you can see, is something that you may not be doing routinely today, but this was something that was being practiced quite extensively in the past. And even today, in certain setups and certain situations, you might actually have to do this. And if you do land up in that situation, most of you would not probably be doing conventional RT. But despite that, as I mentioned at the beginning, it makes sense to go back and look at what people were doing earlier before you start practicing what is available to you now. We move on to urinary bladder, and this is one area of urogenital malignancies which has always been a second-class citizen existence for radiation oncologists. Why? Because traditionally, the surgeons have always had a 10 to 15% benefit over and above what we have been able to give our patients as far as the series for bladder preservation protocols go. And these numbers are basically in survival and not in local control. And that, as you all know, is something that makes us make some treatment protocol as the gold standard of treatment. But things are changing, and we do have a small subgroup of patients where we would probably be able to give equivalent results as compared to our surgical oncology colleagues. And what would those indications be? Between T2A and T3B bladder cancer, alone or in combination with chemotherapy. The alone part probably doesn't exist anymore, except when you're dealing with very poor performance status or elderly patients. Most of them would be in combination with chemotherapy. But what we usually forget, and this I cannot emphasize enough because we keep getting referrals from our surgical oncology colleagues about patients who have been actually suggested bladder conservation protocol radiotherapy. And we basically look at this list to understand whether or not these patients are candidates for bladder conservation. So basically the contraindications that you see here are what you would use to, seed out the patients who do not deserve to undergo a bladder conservation protocol. And what are those? Essentially poor bladder function, tumor within a bladder diverticulum, diffuse bladder involvement, multiple tumors, extensive carcinoma in situ, hydronephrosis, large tumors more than 5 centimeters with or without an extravesical mass. And this is extremely important. Any form of bladder cancer which is not transitional cell carcinoma, do not burn your fingers. And I believe most of us have actually done this and, kind of failed. Considering that radiotherapy is something that we are very confident about. But if you do see an adenocarcinoma or a squamous cell carcinoma, please do not, try to do a bladder conservation in those patients. So what is the role of conventional radiotherapy in 2022 in the context of urinary bladder cancer? So I will stick my neck out and say this should only be done in palliative cases. Why? Many reasons for it. I've just listed out a few. And the first, and I think the most important reason, is that if you look at the data about the doses of radiation in bladder cancers, we have traditionally been restricting ourselves between 64 to 66 gray in phases, of course. And the outcomes of those series of trials have not been very encouraging from the perspective of comparison to surgical oncology. But I think for the first time ever, we have now started kind of matching up to the surgical oncology colleagues the moment we have decided to do hypofractionated radiotherapy in urinary bladder cancers. And there is now enough evidence for us to use this in regular clinical practice. So the protocol of 55 gray in 20 fractions in combination with chemotherapy, neoadjuvant or concurrent, is now gradually gaining a lot of momentum. And I believe in the future, like it has already happened for the prostate, this will also become one of the standards for urinary bladder cancers. And even in our own practice, we have noticed much better outcomes with a hypofractionated protocol as compared to a conventionally fractionated protocol. Now, for you to safely deliver hypofractionation, you cannot do conventional radiation. And that is the reason why I feel that conventional radiotherapy probably should be confined to a subgroup of patients who are not candidates for cure. The second thing that is important is that you're dealing with a structure which has different volumes and different days, despite whatever things you might have actually done to ensure reproducibility of your target volume. And we come to what you could probably do, what is considered to be the standard. as far as simulation for conventional radiation in bladder is concerned. Despite that, there is so much variation in the bladder volume that in modern radiotherapy, in most centers, including mine, we have something called the plan of the day protocol for bladder cancer. And that includes 3 or 4 library plans, which are created for 4 different volumes for an individual patient. We take a daily CBCT and match the closest volume for that particular day and treat the patient with that plan on that day. So that's how difficult it becomes for you to actually delineate the target. So doing conventional radiotherapy there, it just doesn't make any sense if you do that. And finally, lymph node irradiation and post-operative adjuvant radiotherapy, you will get different, outlooks by different authors in different series. The thing to remember here is the surgeons routinely dissect pelvic lymph nodes when they do cystectomies. And some of our textbooks, as well as some of our, guidebooks for radiotherapy planning, do mention the futility of radiating the pelvic nodes, primarily because the doses necessary for us to achieve cell kill for gross disease cannot be achieved in the entire pelvis. If you actually do want to consider that, then it cannot be conventional radiotherapy. So all over again, you're coming to a situation where probably conventional radiotherapy is probably more of historical interest than anything else. And like I mentioned in the beginning, we will go back in time to understand how it was done. So this is how bladder localization was done when conventional radiotherapy was considered to be, acceptable in radiotherapy for bladder cancers, especially in the curative setting. So Foley's catheter inserted shortly after the patient has voided, but you need to measure the post-void urine residual, and this volume is replaced by an equal volume of bladder contrast plus an additional 25 ml of contrast and 15 ml of air, and the patient is immobilized in the supine position. Now, in bladder cancers, you would, if you are planning conventional radiotherapy, would need to simulate your patient actually twice. And this simulation that I just mentioned to you is for the phase 1, where you're treating the bladder along with the pelvic lymph node basin. So this is what the phase 1 portals would look like, and it's a standard pelvic RT portals. There's nothing special here that you probably would need to, concentrate upon. So your superior border is the L5S1, inferior is below the obturator foramen, as you can see there, if you can appreciate that. And laterally, it's 1.5 to 2 centimeters to the bony pelvis at its widest point. The dose would be between 40 to 45 gray at 1.8 to 2 gray per fraction. So for your first 5 weeks, this is what you will be doing in your anterior portal. So this is not just an APPA, it has 2 lateral portals as well. And that is where your bladder visibility becomes an issue. And that is the reason for simulating bladder differently as compared to other pelvic malignancies. So your lateral border, the anterior border would be anterior to the bladder with a margin of 1.5 to 2 centimeters. So that's how you see your bladder inside and you place your portal there. Posteriorly, it would be 2 to 3 centimeters posterior to your bladder. So these would then qualify as your pelvic portals for phase 1 treatment. Going on to boost, and as I mentioned, for your boost, you're primarily going to start looking at treating the bladder alone and trying to avoid as much as possible the adjacent structures. And what has been shown is that you can achieve that much better in conventional radiotherapy if you use the prone position, especially with belly boards, which take the small bowel as far away as possible without any invasive procedures. And for which you need to place the patient in a prone position. And that's where your portals again change. The anterior border would be 1.5 to 2 centimeters away from the bladder. The lateral would be the bladder with a margin of 1.5 to 2. And you basically would select obliques if you can. And in order for you to do that, it is not possible for you to just go with a conventional simulator or a clinical plan. You would probably need 1 or 2 cuts on the CT scan. And you could then digitize that and see the angle at which you would be able to, save the rectum as much as possible. So you're basically trying to do that to reduce the high dose region within the rectum there. So if you have 2 lateral beams, much larger volume of the rectum, this region here comes within your treatment volume or the prescription that you would be doing. With 2 obliques, you are able to create this pentagonal structure which can avoid a part of the rectum and therefore reduce the rectal toxicities. And the doses, as we all know, are between 60 to 66 gray. I believe most of us in the city stop at 64, and very, very rarely do we tend to go up to 66 gray in conventionally fractionated radiation for bladder. Now, moving on to prostate, again, something which it is is the reason why probably all the modern equipment that we use has become so user-friendly and so available to us. It's probably the reason why I say that is because this is one area which has probably been instrumental in making radiation oncologists confident about technology. And the reason again why that is important is because you cannot escalate doses beyond a certain limit without the use of technology. So historically, it has been up to 60 to 64 gray with conventional, which we all know today is gross mismanagement for prostate cancers. You will probably not be able to do much if you actually use those doses in today's day. You can go up to between 70 to 74 gray with 3D CRT, although with questionable toxicity to the rectum. And you can reach doses as high as 76 to 80 gray if you use IMRT with image guidance. So that has produced the results that you have read in your textbooks or you're reading in your textbooks and comparing yourselves to your urosurgical oncology colleagues who have been giving these fantastic cure rates after prostatectomy. So if you want to compare yourself to a surgical oncology colleague, at least in prostate cancer, we cannot do conventional radiotherapy. But then again, what did we do in the past? This is what we used to do. The target volume for prostate used to be prostate and seminal vesicles. Again, something that would change today because you would probably be looking at the Roche formula to decide whether you need to include the entire seminal vesicle or the proximal seminal vesicle and so on. The obturator and the proximal internal and external iliac nodes were traditionally what we used to treat in phase 1. Again, something that you would use the Roche formula to decide in today's time. So this would be the volume. The position is supine with arms over the chest, like is true for most pelvic radiotherapy patients. Now, what are your portals? Again, very, very similar to what you did for your bladder, except, as we all know, the prostate being much lower lying as compared to the bladder, your inferior border would be at the ischial tuberosity and not at the lower border of the obturator foramen. The rest is more or less what you did for your bladder cancer patients. The anterior border here for the lateral portal is also slightly different. It would be at the anteriormost aspect of your pubic symphysis, and the posterior would be at the S2, S3 level. Now, that is essentially to include the internal iliac lymph nodes in the treatment portal that you would be doing this. What about the boost phase, which, as I mentioned previously, included the prostate as well as the seminal vesicles? Superior is 3.5 centimeters above the pubis. Inferior is short of the anal sphincter or caudal to the ischial tuberosity. As you can see that you don't really shift this much. Laterally to include 2/3 of the obturator foramen, and that's what you see there. Now, anteriorly, in your lateral field, it's 1.5 centimeters posterior to the anterior margin of the symphysis pubis there. Now, if we were doing a question answer, I would have asked you, why did you actually do this? Why did you have to move from the anterior margin of the pubic symphysis to 1.5 centimeter posteriorly to the anterior margin of the pubic symphysis? And the answer is there. You see, this is the area of your abdomen which will accommodate the small bowel. So if you were to go back there again for your boost phase, you would then practically be radiating a much larger volume of the small bowel. And in the times of non-contoured and non-3D CRT radiotherapy, that used to be the dose-limiting toxicity for pelvic artery. And most of the papers that you see from that time, that was the issue that was being raised most often. And one of the first things that we did to reduce that was bladder filling protocols. But then again, your bladder filling might not be able to account for the higher volumes of small bowel if you were to place your anterior border of your lateral field at that point. What about your posterior border? It is 2 centimeters behind the rectal marker that you would be placing there. Again, because the rectum is going to be radiated, a part of the rectum is going to be radiated, even in your phase 2, the toxicities are prohibitive. And these were the beam arrangements that you would be doing. A 2-field APPA, again, this would be something that none of us would be talking about today. If you are actually planning to do conventional for prostate, it has to be a 4-field box that you have just been talked to about. And the limitations of 2D is something probably that you were all aware of, and from the exam point of view, something that you can sort of extrapolate on much more than me. So poor nodal coverage is something that we are all aware of about the extent of nodal radiotherapy that we can do with conventional as compared to 3D CRT. You have higher normal tissue toxicity as expected because you are radiating areas of normal tissue, knowing fully well that they are within your treatment portal. And because you are doing that, you cannot escalate doses, as I just mentioned to you, beyond 62. 66 is being very, very, optimistic, but that's what we used to do when we were doing conventional radiotherapy. The biggest problem for us today, not a problem for us when we were residents, we could not see the tumor and they didn't matter to us because we had anatomical landmarks and clinical, areas of interest which we could include within our treatment portals. And the dose to the target volume in organ interest cannot be predicted. Again, something that does not require much explanation. So now probably it's pretty evident why prostate cancer is no longer treated with conventional radiotherapy, except maybe in places where patients do not have access to any form of treatment, let alone proper radiotherapy. So I think this would now become something of historical interest only. Coming to seminoma, and this will be probably going into the last part of today's presentation because I don't know how much more time I have, but this would probably end today's presentation on genitourinary 2D planning for genitourinary malignancy. So we are all aware of the staging of seminoma and non-seminomatous germ cell tumors of the testes. I will not go into details beyond saying what we have been able to achieve in seminoma is primarily because of the type of cells that we are dealing with. So these are cells which undergo interphase death, which is the moment you radiate them, they do not wait to divide. There is no mitotic death that you see. So you radiate and it's gone the next day. So this makes it extremely, and what the textbooks like to call, exquisitely radiosensitive. And that is why the treatment for the doses here, the portals here have existed for time, time immemorial, and we still keep going back to this despite having access to modern radiotherapy, tumor volumes and CT scans and all those things. So it's important for us to realize that seminoma has stood the test of time as far as conventional radiotherapy is concerned. You can do as good a job on any equipment that you may be having if you're dealing with seminoma radiotherapy. So we divide seminomas into 3 stages, stage 1, 2, and 3. As you can see, those are the stage descriptors. What I would love to draw your attention to here is the treatment between this stage 2B and stage 2C. Now, stage 2C, for lack of anything better, is with a lymph node, which is more than 5 centimeters in size, anywhere inside the abdomen. So that is something that you could use as a ballpark to be able to answer questions when you're asked so during exams. So anything less than 5 centimeters, you can do a fair job with radiotherapy and get away without having to subject the patient to systemic therapy like chemo and so on. But anything beyond 5 centimeters, it starts becoming a question mark. We'll go into a little bit of literature review before we talk about the portals here because it's important for seminoma. So what about adjuvant radiation for stage 1 seminoma? Now, you have to know the history here. It was a point in time in the past where we were not even aware of what radiation could do in the long term to certain critical structures, and that included cardiac, lung, and so on and so forth. So historically, seminoma had been treated with orchidectomy, with inguinal para-aortic radiotherapy, and sometimes also mediastinal endartery, because at that point in time, the thought was that if there is an area of lymph node involvement, you have to treat one level above that. So if you had para-aortic lymph node, it made sense to then go one level above and treat the mediastinal lymph nodes. But in the 60s and 70s, we started realizing the cardiac mortality associated with mediastinal artery. And as you're all aware, seminoma is a disease of the young adult. And all these young adults were turning into old adults in a very short period of time because of the cardiac problems they were developing. So it was abandoned in the 60s. But para-aortic plus ipsilateral iliac lymph node, which is also traditionally known as dog leg, at 13, 15 became the standard. So this persisted for quite some time. But the first challenge that happened was whether you need dogleg fields or you can get away with para-aortic fields. So you had this study published in 1999 by Fossa et al. And they did a study where they randomized 470 men with stage 1 to para-aortic versus dogleg. The doses have still fixed at 30 grays, and the median follow-up, as you can see, was about approximately 5 years. So the 3-year relapse-free survival for dogleg and para-aortic RT were almost identical. The overall survival almost identical. The pelvic relapse rate for omitting radiotherapy to the pelvis was slightly higher when you look at para-aortic artery, or basically when you omit pelvic artery on the ipsilateral side. So there was not essentially much of a difference. And remember, seminoma is a disease which is eminently salvageable even if you have a nodal recurrence going into the future. So that is the first question which arose as to whether a dog leg is required or not. And very rarely do we now practice dog leg, even if we are doing radiation for seminoma in most of our patients, unless you have positive pelvic lymph nodes that you are able to appreciate on your imaging. Next, we come to the dose required, and the 30 gray was challenged by the URTC 30942 with 625 patients, where they basically did a 20 gray in 10 fraction versus a 30 gray in 15 fractions. And they saw the relapse rates between the two. And again, they saw that the relapse rates were almost similar for patients between the two arms, but the toxicities were definitely higher for the higher dose protocol. But then these toxicities were time limited, as in they went away with time. But that is not what we are interested in. What we are more interested in is the late side effects. And if you go to the early 2000s and even today, you have multiple papers coming out about the incidence of hypertension in patients who have undergone radiotherapy for the para-aortic lesion in the long term for seminoma testes. And this has prompted us to choose lower doses for avoiding long-term complications of radiation in this group of patients. Coming next to reduction in field size, and this has been an area of interest primarily because of the mediastinal data. So we're trying to reduce the superior edge of the para-aortic field, get it as far away from the cardiac shadow as possible. So this is mainly a retrospective analysis where you basically see people comparing T11, T12 versus the historical T10, T11, and there was a median reduction of the treatment volume of 16% without a change in the outcome of treatment. And the conclusion from this particular retrospective study was you can actually safely come down to T11, T12 from the traditional T10, T11 if you're talking about radiation to the para-aortic lymph nodes. Now come directly to the technique now. So you are going to be simulating these patients in a supine with arms placed on the patient's side, the legs straight with feet stabilized with foam wedge underneath the knees. The body cast can also be used, and the position of the penis has to be outside of the field, which is something that would probably happen on its own. The shielding to the contralateral testes with the lead clamshell device is something that has been recommended routinely, and these are the doses that you would be able to achieve with and without a shield if you were doing PA versus PA plus ipsilateral iliac, that's the dogleg field. So slightly higher doses when you do dogleg for the contralateral testes, as expected, but with the shield, you can significantly reduce the doses if you are actually planning to do a dogleg in any of your patients. So how would you treat a stage 1? The field margin at superior would be T11, T12 as we saw. The inferior would be at the L5S1 interspace. The lateral will be covering the lateral, the transverse processes of the vertebra being treated. And for the left testis, this is important because the drainage of the left testis is the left renal vein. So you would be covering the left renal hilum there, as you can see, this area, which does not match to the opposite side. The dose is 20 grain 10 fractions to para-aortic plus minus pelvic lymph nodes by an APPAT. So the plus minus part is basically where you start talking about stage 2. So in seminoma stage 2, the treatment would depend on the bulk of retroperitoneal nodes. So as I mentioned, 2A and 2B nodes below 5 centimeters, you can get away with 25 to 35 gray dose to the involved node after doing phase 1 for the entire nodal station. The disease-specific survival rates are extremely acceptable. The recurrence rates are also very low. And the most common sites of recurrence would be distal to the area being radiated. What is important here, and a question which is commonly raised, is then why don't we combine chemotherapy with radiation in this group of patients? Because it has been shown that by addition of chemotherapy in this protocol, there hasn't been much of an advantage, and so we confine ourselves to radiation alone. Now, whether single agent carboplatin has challenged this paradigm of radiation at all is a topic for a separate symposium or a debate or a presentation. I would not be going into that today. So this is how you would do a dog leg or ipsilateral inguinal and a pelvic field along with the parietic field. So the superior border remains the same, but the inferior border shifts down to the mid-obturator foramen there. And what about the lateral border? It transversely passes down through the L5-S1 space, then diagonally to the lateral edge of the acetabulum. So in the diagram, they might have actually misrepresented that, goes back a little more on the other side and vertically down to the medial border of the obturator foramen there. So that's how you would design for your dogleg field. We'll look at modified dogleg also in a subsequent slide. So the doses that you would be doing is 25 grain, 20 fractions by APPA. You're reducing the dose per fraction because of the interface depth of the seminoma cells as well as the reduction of toxicity by reducing the dose per fraction per day. But if you have larger lymph nodes, you would be going in and putting in a boost of 10 to 10 grain 5 fractions to the involved node. Now, this would require you to at least have the capacity to delineate the lymph node. So even if you're doing conventional radiotherapy, it would then make sense for you to take a CT scan, you delineate the area, do a proper segmentation of at least the lymph node, and then design your portals to be able to cover the lymph node adequately. And you definitely also need on-table, verification to be able to have more confidence in what you've been able to achieve. Now, just to give you a little bit of idea about dogleg and modified dogleg, this is what a dogleg looks like. So as we mentioned, T10, T11 or T11, T12, depending on what you're doing. A renal hilum has to be included on the left side. This is what, it's a better diagram, so I thought I should include that. At the mid L4 level, the field is extended laterally to cover the ipsilateral external iliac lymph node, as you can see. And traditionally, the inferior border is placed at the superior border of the obturator foramen, as you can see there. But what is modified dogleg? The superior border is the bottom of the body of T11. Inferior border is at the top of the acetabulum. There, as you can see. The medial border of the lower aspect of the modified dogleg extends from the tip of the contralateral transverse process of L5 down towards the medial border of the ipsilateral obturator foramen. So that's how it goes. The lateral border for the lower aspect of the modified dogleg is defined by a line from the tip of the ipsilateral transverse process of L5 to the superior lateral border of the ipsilateral acetabulum. So all of this is for a situation where you do not have access to 3D planning with the help of CT segmentation and so on. So I think that is my last slide, and I will be very happy to take questions if there are any.
Thank you, sir. Thank you for such nice presentation. And I think it will be very helpful for the resident, particularly from exam point of view. And so I would like to request the resident also to ask questions. I think there is one question in the chat box. So is there any guideline for adrenal carcinoma, and what is the margin of GTV tumor bed, and should the regional nodes be included? I think
to the best of my knowledge, I do not have access to any guideline regarding adrenal cancer management. But if you look at the location of the adrenals, one of the first things you would realize there is, and this is true for most cancers that we treat with radiotherapy, the doses would be dictated by the organs at risk surrounding your target volume. And you have the kidney sitting right below it and the small bowel, and depending on which side the adrenal is, you might have the liver sitting next to it or the stomach and so on and so forth. So you will be extremely constrained when it comes to margins, when it comes to radiating adrenal cancers. And in the last 20 years or so that I might have been in the subject, I don't remember having seen radiotherapy for adrenal cancer. So I guess if any other experts around have done it, they would be able to answer. Subarna madam or Munidipa, if you have any experience.
Yeah, I haven't seen in my entire career about treating an adrenal cancer with radiotherapy. So I think.
So we would, love to hear from you if you can do a literature review and let us know in the next class. If you managed to find something regarding this?
Yes, of course. Madam, any comment from your side?
Dr. Amitabh Ray, as usual, and I think this is very beneficial for our residents. Am I audible?
Yes.
Yes, ma'am.
Yes, yes, yes. Also, thank you all for, if there is any question more?
No, there was only one question that has been already answered by Dr. Nikhila actually.
Okay. With the lecture of Amitabh Ray, I can remember my post-graduation days. You know, this was a 2D era, and at that time, it was very fascinating to treat seminoma in an early stage because he was showing this dog leg radiotherapy. So I can recapitulate my time, my post-graduation time. Thank you, Amitabh, for your excellent
ma'am. Thank you
deliberation.
so much. Thank you.
Excellent. So we can conclude the session now. Is it, Manideepa?
Yes, ma'am. Thank you.
Okay,
all the
thank you.
faculties, our expert, and also all the residents for joining it. Our next class will be on 2nd of November because next Wednesday is I think Bhai Dooj is there. So next class will be on 2nd of November, GU Part 2, which deals with the 3D planning mostly. And thank you again, everyone, for joining. With that, we conclude the class today.
Thank you.